Delirium is defined as a multifactorial neuropsychiatric syndrome which has an acute onset that results from global organic cerebral dysfunction and all too often may go undetected or misdiagnosed, which can lead patients to being improperly and unethically treated and or medicated. Delirium can be broken down into 3 different types of delirium. There's hyperactive, hypoactive, and mixed delirium. And you can see the signs and symptoms for each on the screen. Hyperactive typically presents with agitation and aggression, incoherent speech, disorganized thoughts, delusions, hallucinations, and disorientation. Hypoactive delirium, the patients will be more sluggish or drowsy. They're pretty hard to arouse. They're less reactive and sullen, and they look withdrawn. Your mixed delirium patients may have interchangeable symptoms of both hyper and hypoactive delirium. This really disturbs their sleep-wake cycle, and it can make patients very exhausted. As you can see with the percentages listed, delirium can occur in lots of different situations, and it is very prevalent upon the elderly population, especially in hospital setting. The mechanisms of delirium are not well understood, and there are known causes of delirium, which include infections such as pneumonia, respiratory infections, UTI, sepsis, skin or soft tissue infections, dehydration, falls or head injuries, hypoxemia or hypercarbia. And then when you think about groups of people who use alcohol and recreational drugs, the geriatric population is not really the first one to come to mind. However, you do have to keep it in the back of your mind that patients may be weaning off of alcohol or some type of narcotic. Medications can cause delirium as well. Drug toxicity contributes to approximately 30% of all cases of delirium. So clinicians must be aware that delirium can occur even within therapeutic levels of such drugs as digoxin and lithium. Diagnosing a patient with delirium can be sort of tricky. Distinguishing the 3 Ds of your geriatric population is a difficult task for most practitioners. You have to be very familiar with each syndrome and how they present, especially in the hospitalized patients and for patients that you do not have a good history on or who do not have family members that can provide you with their daily norm. So the differences between the 3, we'll start with delirium. Delirium symptoms will typically start suddenly. It's in a very acute process. The symptoms are typically temporary. They resolve when the underlying cause is addressed. Sometimes this can take hours, it may even take days, and on the rare occasion, it can last weeks up to a few months after the patient's discharged from the hospital. Dementia, these patients typically present with symptoms that have progressed over months to years. Early on in the disease process, these patients will be alert and oriented with normal behaviors, and then the symptoms just, like I said, progressively become worse over time. Typically, dementia patients do not have the hallucinations that are present with your delirium patients. For depression can manifest very differently in the older adult population. Your typical younger patients will present with sadness or feeling blue, but your elderly population may come in and their complaints may be that they feel tired or that they're having problems with attention or focusing. They're having difficulty sleeping or that their wake and sleep cycles are messed up. These issues with sleep can cause them to have a great deal of irritability and then become very confused, and these can mimic as symptoms of dementia or Alzheimer's disease. And on the next slide, we'll show how there may be ambiguity of what's really going on between these diagnoses. The overlapping symptoms of delirium and dementia can be very hard to distinguish, especially in patients with pre-existing dementia. For example, the patient for this presentation already had a history of becoming agitated several times per week due to his dementia. He also had difficulty sleeping at times, and at times he would also have problems with attention, orientation, his memory, also the way he was thinking. And so it was very important that the providers were familiar with the differentiating factors of time course, whether the onset of presentation is acute or gradual. The cause of new behaviors is very important, and which interventions to use and which ones will be best to decrease the behaviors are also very important. And as you can see on the chart, delirium versus dementia, talked about the onset already. Between the two is different. The course with delirium, the patient's behaviors may wax and wane, just depending on the cause or the time of day. And with the dementia, the course is progressive. The duration, like we talked about before, the difference there is still an acute course. And with consciousness, your patients are going to be reduced or agitated when they have delirium. And in your dementia patients, they're going to have a more clear state of consciousness. Attention is going to be impaired, orientation will be impaired, their memory will be impaired. And that's when it starts to get more gray, because with your dementia patients, in the early stages of dementia, their attention is still normal. But as they progress, they can be impaired, as well as their orientation and their memory, depending on their stage again. So it can be difficult to diagnose these patients, like I said, especially without a great history. The patient that I chose for this presentation was an 83-year-old male. He is very established at the practice where I'm doing clinical, and so we were seeing him for hospital follow-up after admission for TFN of the left hip after he had a fall at home. He is very healthy. His past medical history includes diagnosis of primary open-angle glaucoma, disorder of refraction accommodation, hypothyroidism, Alzheimer's dementia without behavioral disturbance, and unspecified bilateral hearing loss. He's only been hospitalized twice in his life, including for the TFN. The other time was for appendicitis. You can see there his allergies, his medications, and again, he is just a very healthy individual overall. He's up to date on all of his immunizations. As far as health maintenance and disease prevention, based on his last colonoscopy at age 75, he's chosen not to have any further screenings, and it's recommended that he does continue to have his annual physicals and his annual lab work to monitor kidney and liver function, along with standard CBC and lipid panel. He has no family history of prostate cancer, so his PSAs through age 75 are always within normal limits. So unless he develops any further issues, he does defer to have any further prostate screenings. Mr. S typically presents to clinic with his wife. His mood and affect are very positive and pleasant. He's ambulatory without assistance. He lives at home with his wife, who is his primary caregiver. They've been married for 58 years, and they have 3 children. One daughter lives approximately 20 minutes away and provides assistance to her mother for relief and respite care when needed. Per the EMR and Mr. S, the patient presented with increased confusion and agitation approximately 48 hours after the TFN. He was not sleeping well and complaining of increased pain after the surgery when his spinal anesthesia wore off. And his wife noticed that he'd become increasingly agitated and did not recognize her or their daughter, and he seemed upset and afraid. Patients do not typically have complaints specific to delirium, but rather the underlying causes of delirium. It can be difficult with patients who have pre-existing advanced dementia to recognize delirium, and it's very important to have family involvement when available to help decipher those behaviors from the patient's normal behaviors. As you can see, the objective data above was pretty good. His vital signs were all within normal limits. He presented to the office for follow-up and was alert and oriented to person and place, which was his normal before the hospitalization. He's afebrile and he's not in any sort of distress. He has his hearing aids on, and he is also wearing his glasses. His left hip incision is healed. He does have a scar. There's no bruising noted. There's no issues with his lungs or heart during this visit. His strength is 4 out of 5, and he is using a walker with ambulation for stability, whereas before he was independent. And he is also going to physical therapy. And so we did the mini mental status exam. He scored a 15. So he does have cognitive impairment. Recent and remote memory is impaired. Perceptual ability, judgment, and reasoning, decision-making capacity is also impaired. And supervision is required, and his wife does provide that supervision. The screening tools I chose were the mini mental status examination, caregiver strain scale, Montreal cognitive assessment, and the clock drawing test. This patient scored a 15 of 30 on the mini mental, which indicates a moderate degree of impairment, meaning that he has clear impairment and may need 24-hour supervision. His wife does provide that supervision, and she states that he does require more assistance now than before he did, before the fall. However, he does continue to follow directions well, but he does have trouble with short-term memory, moderate tasks like bathing and dressing. He does not wander, but he has started to develop some symptoms of sundowning and becomes increasingly confused throughout the evening. The caregiver strain scale indicates a need for further intervention in areas that are checked yes. His wife scored a 5 of 7. And the areas that she requires intervention include physical strain, decreased sleep, making family adjustments, financial strain, and increased behaviors at night. She states that for the majority of the time, her husband's very pleasant to be around, and they can still take short trips out and visit family and friends. She states that her daughter assists her with the majority of the shopping, and she also attends all doctor's appointments. We also performed the Montreal cognitive assessment for this patient, which includes the clock drawing test. Any score less than 25 is considered to be an indication of some form of cognitive impairment and can predict or identify the onset of dementia in patients. And as you can see, he did score well below 25. And for the clock drawing test, he scored a 4, which means he demonstrated the ability to follow some instruction. The clock face was attempted, but either there were no numbers or the numbers were in the incorrect place or outside of the clock face, which you can see is what he had tried to do there. I also did the functional assessment staging test, or the FAST, and this is used to assess the patient's level of dementia. It's a 7-stage system based on one's level of functioning and ability to perform daily living activities. So on a scale of 1 to 7, this patient scored at a 5, which is moderate Alzheimer's, meaning he requires assistance with basic ADLs such as choosing proper clothing. Early diagnosis of delirium is key for early treatment and optimal patient outcomes. Identification of the underlying etiology is imperative. Identification of these causes are typically made with a thorough history and physical, lab work such as CBC with DIF, CMP, magnesium, blood cultures, O2 saturation, and observation of vital signs, assessment of pain, injury, and/or falls. Patients who are at high risk for delirium include patients who have a history of delirium, those who are surgical post-op patients, especially those who are receiving narcotic pain medications, benzos, or that during surgery may have received hypnotics, general anesthesia, or anticholinergics. Patients with underlying diseases such as dementia, constipation, UTI, and pneumonia are also at high risk. Because delirium can be manifested many different ways, and to the untrained staff, the patients may appear overly agitated, leading to unnecessary and unethical pharmacological interventions, when in fact, non-pharmacological interventions are the mainstay of managing delirium. The very first step to the treatment in delirium is identification of the correct diagnosis, and then, if at all possible, identifying the causative factor and making changes to the patient's plan of care based on the causative etiology. Differentials for this patient would include dementia, acute systemic infection, and electrolyte imbalance. The dementia could be ruled out with historical information, the onset of behaviors, and how quickly the new or changed behaviors began. Acute systemic infection could be ruled out with assessment of vital signs, physical exam, lab work, and blood cultures. The electrolyte imbalance can be ruled out through a thorough through obtaining serum electrolytes, plasma glucose, and urinalysis. Post-operative delirium was chosen as a diagnosis for this patient due to the fact that he did have the fall with injury, he had associated pain, and then a surgical procedure and medications, which can increase the risk of delirium in the elderly post-op hospitalized patient. Barriers to his care include managing his increased level of pain without administering medications that would enhance his delirium. Numerous measures were taken to decrease his risk of delirium, including the administration of 900 milligrams of gabapentin preoperatively, along with a gram of Tylenol, and the use of spinal anesthesia versus general anesthesia. Management of his pain was established in the PACU. However, the patient did have severe pain within the first 24 hours post-operatively and received additional narcotics, which further increased his risk of delirium. His management at home would be to continue to manage his pain and use non-pharmaceutical interventions. He could do ice to the affected area. He is receiving physical therapy. He will need to do his at-home exercises and then use non-narcotic pain medications. Community resources include the Senior Citizens Outreach Program, Respite Care, and the Ruby Purdue Blackburn Adult Day Healthcare Center. These local resources are very impressive for our area and are geared towards seniors and provide all levels of service. Respite Care is offered to families in our community through several different services and agencies. These programs allow caregivers of homebound patients or persons with Alzheimer's and dementia the opportunity to leave their homes and run errands. The Ruby Purdue Blackburn Adult Day Healthcare Center provides a safe home-like environment for adults which cannot remain safely at home during the day while their caregivers have to go to work or run errands. So these are several different facilities that are available to seniors in our area. Providing the correct intervention for patients with delirium can be a daunting task for any provider. First, as providers, we are to do no harm to our patients, but at the same time, we must also ensure the patient remains safe and that they do not harm themselves or the staff. However, by simply medicating and restraining a patient suffering with delirium without further investigating the cause is simply unethical and could be avoided with proper training. A trial of medications can be helpful in many acute cases of delirium. As a provider, you must consider the side effects that come along with pharmacological therapies. Non-pharmacological approaches continue to be the mainstay for treatment of delirium and is always the most ethical option. If these approaches are going to be successful, providers and clinical staff must be properly educated and understand what they are observing when they witness the agitation of delirium. Whether delirium is hyperactive, hypoactive, or both, there is a role for a proactive, non-pharmacological approach consisting of at least 3 principles. Those principles are: the brain works better when upright, delirium goes down when ambulation goes up, and the TDAW method. Tolerate, anticipate, and don't agitate your patient. The TDAW method is based on 2 decades of experience in a specialized unit called the Delirium unit. Behaviors that were demonstrated there were observed, and staff were to always anticipate actions of patients and be ready to respond. The most obvious but subtle principle is don't agitate. And last but not least, if an intervention, say reorientation, is working, that's great. If not, stop doing it and stop continuing to agitate your patient. And in conclusion, provider education and assessment training is imperative for the diagnosis and treatment of delirium. Education and training when planning interventions for patients with delirium are the key principles. Evaluate the patient thoroughly to discover the underlying cause of the delirium while continuing to provide the patient with a safe therapeutic environment, and when at all possible, implement non-pharmacological interventions while you treat the true source of the delirium.